University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past. And we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. So just a few housekeeping details before I introduce today's speaker. So all of you have coffee, which is great. So you know where the coffee and the water is. Please always help yourself. There's cookies afterwards. You know where the washrooms are and whatnot. We are recording today's session, so if you wanted to watch it, listen to it again, if you want to share it with friends, we really encourage you to do that. We have a Learning for Life YouTube channel or YouTube part on our YouTube channel. So I encourage you to do that, and it will be up on our website fairly soon after today's session. Also, I wanted to thank our affinity partner, I Financial Group, who is a sponsor of this program, who helps offset some of the costs for the program as well. So let's move on to our main event today, and I'm very pleased to welcome Dr. Rady Souleymanov, who will be presenting on the topic of improving the health outcomes of marginalized people in Manitoba, findings from infectious disease and addictions research. Let me tell you a little bit about him. He's an assistant professor in the Faculty of Social Work. He's also the director of Village Lab, which you see that logo on the screen in front of you. His interdisciplinary program of study focuses on the impacts of oppression and injustice on the health and well-being of socially and economically marginalized communities, particularly those who are living with HIV, sexual and gender minority men and Two-Spirit people, Indigenous people, immigrants and refugees, blood donors, and people who use drugs. He also currently is serving on the board of directors of 9 Circles Community Health Center, and is a stewardship member of the Manitoba HIV STBBI Collective Impact Network. He's a member of the University of Manitoba Senate Committee on Admissions and the Senate Committee on Appeals and Executive Committee. I could go on. He's done a lot. He's also received a number of grants for his work. And he's also currently the co-investigator on 10 different Canadian and internationally community-based research projects, which is amazing. I don't know how you find the time. So with that, over to you, Rady.
Thank you so much. I try to find time. I have no social life. Thank you so much for having me here. It's really a pleasure to be spending the next hour with you. So my name is Rady Souleymanov. I use he, him pronouns. I am an assistant professor in the Faculty of Social Work. I'm also cross-appointed to the Department of Community Health Sciences now. And I am running our little community-based health research lab. As you can see, the Village Lab, where we do a variety of research projects with marginalized communities. So today's presentation is titled Improving the Health Outcomes of Marginalized People in Manitoba, Findings from Infectious Disease and Addictions Research. Before I start, I would also like to do a quick land acknowledgement. It's really nice to kind of ground us before we move any further. There's just so much stuff happening in the world, like, continuation of pandemics, wars and everything. So it's just nice for us to just take a moment, ground ourselves. The work that I do and where I live is on Treaty 1 territory here, the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, the homeland of the Métis Nation. And as you probably know, the water that sustains all life here in Winnipeg is sourced from the Shoal Lake 40 First Nation. So it is with that grounding in mind, I am now going to proceed with my presentation. So Village Lab, this concept, this lab has emerged in 2 years ago approximately. The central theme of this series is lifelong learning, and I'm definitely a lifelong learner. After I finished my bachelor's degree in psychology, I did my master's and PhD in social work and collaborative program in public health policy at University of Toronto. And after I completed that, I got this wonderful job here as a professor. But one thing was missing from my work. It's one thing that was missing is this part of kind of knowledge generation, creating knowledge. How do we create knowledge to affect policies? How do we create knowledge to affect practices, service provision? So with that in mind, really, this is why I decided to start this lab, this research lab, to be able to really impact our services in Manitoba. Moving here from Ontario, some of the things that I knew right away that were really not working well here in the province are our super high rates of HIV and other sexually transmitted and blood-borne infections. We knew that there were quite a lot of issues when it comes to substance use and addictions and a variety of social determinants of health that were not working well in Manitoba. Manitoba is also one of the poorest provinces in Canada. It has the second highest rates of HIV after Saskatchewan. So there was a lot of reasons why I thought it just made sense for me to move here and to continue my work impacting communities and services and policymakers, funders, and strategists. So Village Lab emerged as this research hub. What we do at the Village Lab is a very interdisciplinary work. My background is in social work, public health, and psychology, and so I bring that interdisciplinary focus in the research that I do. So what do we do in the Village Lab? It's a community-based health research lab. We focus on HIV. STDBI stands for sexually transmitted and blood-borne infections, a variety of social determinants of health, harm reduction, which is one of the approaches to dealing with substance use, addictions. And so we conduct really kind of rigorous applied social science and health research. And then we use this research to affect social policies, public health policies, and social service practices. The lab is currently staffed by myself, the director, an elder, and knowledge keepers who are guiding our work, and also 15 staff members, which includes research assistants, peers who are hired, the Village Lab manager, graduate students, undergraduate students, and a variety of other partners and stakeholders. And over the last 2 years, we've been just really lucky to be funded by the federal government and the Canadian Institute of Health Research, which is the largest health funder in Canada. And we were really lucky to receive over $1.2 million over the past 2 years to conduct a variety of research projects with marginalized communities in our province. CIHR, if you're not familiar, it stands for the Canadian Institute for Health Research, which is once again our biggest health funder. And the work that we do in the lab in terms of actual project, there's quite a few of them, and I'll be touching on a few of them, so be prepared that the next few slides are going to be about research. So we work with a variety of populations, as was mentioned in the introduction. 2S LGBTQIA communities, which is a large kind of acronym, two-spirit, lesbian, gay, bisexual, trans, queer, intersex, asexual. It's a big, large term for a whole umbrella of sexual and gender minority communities. We also do a lot of work with First Nations, Inuit and Métis people, our indigenous communities here of this lands. A variety of projects focused on Black, African, Caribbean communities, refugees, migrants, folks who use injection drugs in particular, and people who actually live with HIV, hepatitis, and other health issues. So there's five different, kind of a signature project. There's way more than 5, but those are the ones that are significantly funded and something that I will be sharing with you information about today. One project that we currently have going on, the first one here is called the Gigibapaman study. Gigibapaman is an Ojibwe term which translates as "we survived." It's a term that's rooted in optimism, and it's a study that focuses on how people, indigenous people who are living with HIV, how they fared during the COVID-19 pandemic. The second, our big signature project is Ubuntu Pamoja study. Ubuntu Pamoja translates as humanity towards everything. It's a Swahili term, and this project focuses specifically on Black African Caribbean communities. And with that project, we're trying to look at innovations in HIV testing for this community. The Migration and Health study is a project. Anyways, the third project. It's focusing on the most pressing sexual health needs, mental health needs, physical needs, so kind of health needs of migrant populations in Manitoba. And the last two projects are focusing on a subsection of 2S LGBT community, the Manitoba 2SGBQM Men's Health Study. 2SGBQM stands for Two-Spirit, Gay, Bisexual, Queer. Just some of the identities there. This study we conducted before the COVID-19 pandemic, and then the last one after COVID-19 pandemic. So what I'll do right now is I'll take you through some of the studies, and I will show you some of the kind of the taste of equity when it comes to health service access. I'll speak a little bit about that relationship between marginalization and health outcomes. Marginalization and healthcare access, oppression and healthcare access. That's the larger theme that runs through most of the projects that we do. So the first one that I decided to start with today is called the Manitoba Two-Spirit, Gay, Bisexual, and Queer Men's Health Study. So here for this project, we specifically looked at the population of sexual and gender minority men. And the reason why we're focusing is some of it comes from epidemiological data, which tells us in Canada that this population is unfortunately overrepresented in HIV statistics. And so there was also no studies taking place in Manitoba before we initiated this project on this population. So really a dearth of research. When it comes, for example, to service provision, service providers have no knowledge to really inform their practices. So we quickly identified this as a gap, and we decided to apply to funders for this project, I believe in 2018, 2019, so just a year before the pandemic started. And this project was a collaboration with multiple partners, as you can see the logos of different partners here, including 9 Circles, Rainbow Resource Center, Two-Spirit People of Manitoba, Winnipeg Regional Health Authority, our own health center. So maybe you recognize some of the agencies in the community here. To be eligible for this project, participants had to self-identify with one of those cultural identities. They had to be at least 18 years of age, and they had to live in Manitoba. So one of the things that I want to kind of show you, one of the drastic findings that we found right away from this project, just the amount of discrimination and social exclusion that this community faces in healthcare settings. It was a pretty big study, 343. So that's on the corner, in the right corner, n equals 343. It's the total sample size. How many people in total participated in this survey? And among those 343, 65%, a little bit over 65.3% told us that they're experiencing discrimination in Manitoba when it comes to access, when it comes to healthcare settings. That's a very high percentage of individuals, 222 individuals who are telling us that they're experiencing that discrimination. So we started tapping deeper into that. So when you say discrimination, what exactly do you mean, right? Because when somebody's identity, like, it's not just kind of a monolithic gay, bi identity. There could be intersection of identities. Maybe it's also something about age, ethnicity, I don't know, some other social location or identity marker. So we asked them why. Why do you think you were discriminated against? And we got different answers here. So within this community, here are some of the responses that we have received. So a little bit over 32% indicated that they've been discriminated specifically because of their sexual orientation, sexual identity, sexuality. 26% indicated that it was because of their gender identity or gender expression. Almost 25% indicated that it was because of their ethnicity or racial identity or skin color. 7.6% because of their indigenous identity or heritage. 7% said that it was due to their pre-existing health conditions, disabilities, and 7% specifically said that it was because of their HIV status. 6.4% said it was because of their substance use, approximately 6% because of age, and 4.7% because of involvement in sex work. So a variety of reasons why people were discriminated. We also asked people, okay, so when you go to your doctor, when you go to a healthcare provider, what do you actually reveal to them? Like, do you talk about your sexual orientation? Do you talk about your sexual identity? And approximately 25.5% said no. That's not something I talk with my healthcare provider, with my doctor about. Maybe there's no space, maybe there's no reason, but maybe the healthcare provider is just not doing a good enough job. Maybe the healthcare settings are also not so conducive. And we're talking about the HIV epidemic taking place, right? We're talking about how important it is actually maybe to speak about your sexual practices, sexualities to your healthcare provider. Maybe they will offer you an HIV test as part of the routine health checkup, right? So 25.5% do not talk to their healthcare providers about their sexual orientation. So we started investigating this deeper. What does it mean? What does this type of silencing means in healthcare settings? What we did find is that this type of sexuality disclosure has a huge effect on HIV testing and a huge effect on testing for sexually transmitted and blood-borne infections. So let me reiterate. 25.5% said that they don't talk to their healthcare provider about their sexuality. Our findings indicated, when we did additional analysis, they indicated that there was a strong relationship between that disclosure or non-disclosure of sexual orientation and HIV testing. With individuals who did talk to their healthcare providers about their sexuality, they were more likely to be tested for HIV and STDs. If you're kind of a numbers person, what we actually found is that those people who did speak to their healthcare providers about their sexuality practices were 9 times more likely to be offered an HIV test and 5 times more likely to be offered a test for sexually transmitted infections. So one of the big recommendations that did emerge from our research that we were able to publish in the British Medical Journal was the importance of competencies. Our service providers maybe are not as competent as we think they are when it comes to creating those spaces where people would be more comfortable sharing about their sexual practices, sexualities. It could be sexuality-related stigma. It could be homophobia, transphobia, but it could be also that service providers just don't have capacity. They just don't know how to initiate those conversations with somebody about people's sexualities. But this community still needs access to safe, non-judgmental, culturally responsive healthcare from providers who understand their needs, mental, social, sexual health needs. So that's kind of what emerged from our first project. A few years later, the COVID-19 pandemic started, and we initiated another project really quickly. We had to mobilize really quickly. We anecdotally started hearing from communities that, hey, all the services are on lockdown. I can't access anything. Something might have happened, and I'm thinking now maybe I'm at risk for HIV. How do I get tested if there's no access? So we're like, okay, this is a problem. We need to do quickly research to understand how HIV testing was affected, how access to testing, to services was affected. So we quickly initiated this provincial survey across Manitoba, and we tried to understand the impacts of the COVID-19 pandemic on access to sexual health services and HIV testing among the same population, two-spirit, gay, bi, queer men. And what we found here is that, so this is the data that came last year, approximately 30% said that their access was affected. It's not a huge percentage of people, but 30% of individuals. Think about it. You cannot get an HIV test, but maybe you are a carrier of HIV, so no testing means you might be continuing sexual practices, spreading HIV in the community. So it's not a good situation, basically. 30% reported that they didn't have access to HIV testing, and not surprisingly, a lot of disparities when it comes to geographic location. So people in Winnipeg actually had okay access to testing, okay access to services, but those folks who lived in Brandon, and as well as those who lived in rural, remote areas were having a significantly reduced access to HIV testing. So that's kind of the main findings that emerged from these two projects with these communities. We need to think more about how we can improve those sexual health services in rural, remote areas in Manitoba, on reserves in Manitoba. We also need to think more about all those structural barriers and how to remove them and start. The pandemic is still with us, but we have to start thinking, how do we create services? Maybe post-pandemic is not the best term because pandemic is still with us, but what are we doing right now? What are the lessons that we're learning from this pandemic? Yes, this research was conducted with this very specific populations, but I think you could also think about other populations and how and how the pandemic has affected many different marginalized populations in Manitoba. So those two studies were about two-spirit, gay, bi, queer men. I'm now switching to a different population. And I'm going to present you some data from a research project that focused on racialized migrants in Manitoba. So we use that term, racialized migrants, in reference to people who are racialized, who are migrants, refugees, people of color. Specifically for this project, we looked at some specific populations like Black, African, Caribbean populations, Latino, Latin American communities, South Asian communities, East Asian communities, and Southeast Asian communities. So a variety of folks from racialized communities. And this project was conducted with an aim to better understand the health, the well-being of racialized migrants and refugees. So I use the term migrant to refer to both refugees and immigrants, but there's distinction, right? Refugees is one type of status, immigrants is another type of status. So this project was a collaboration between different community-based organizations, 9 circles, CERC, Sexuality Education Resource Center, Public Health Agency of Canada, Mount Carmel Clinic, and participants had to live in Manitoba and be at least 18 years of age or older. And we conducted in-person interviews until we got affected by the pandemic, and then the interviews became phone or online Zoom interviews. And here we have a little bit of an infographic to show you what are some of the main findings that have emerged from this research projects with refugee and immigrant communities in Manitoba. This was a qualitative research project, so we did 34 interviews with community members, and then we also decided to do 10 more interviews with service providers. So we had a nice perspective of community members juxtaposed with perspectives of service providers. And what we found here is that there's very little in Manitoba when it comes to sexual health information specifically directed at migrant communities. So participants in our study really spoke about these gaps in sexual health knowledge, lack of sexual health awareness also in their communities. Many people had simple questions like, what is HIV? What is STI, right? So I think there's a continued need, one thing that emerged from our project, continued need for HIV education, sexual health education, prevention. Migrants often commented on the need for service providers to be able to do better referrals to health clinics, organizations that offer sexual health services. In Manitoba, we have 2 different sectors working in silos. We have settlement sector, working with immigrants and refugees, and then we have the health sector, the HIV health sector. And these 2 sectors don't talk to each other. So when people do referrals, there's an issue, like how do you kind of collaborate? How do you do kind of that work across those silos? So part of our recommendation is to create those platforms in Manitoba, to bring those 2 different sectors together for the betterment of the health and well-being of some of those marginalized communities. Migrants talked a lot about the need for trauma-informed care. A lot of communities, when they migrate, they might be exposed to a variety of traumas related to migration traumas, other traumas. And so the trauma-informed care emerged as this essential need in the community. We need to start training our service providers in more trauma-informed care. Anti-stigma campaigns is another important need that emerged. People are not very open to talk about, my research is all about sex and drugs. And people are not very open to talk about these topics, right? But it does affect people's health, right? When it comes to public health, population health, community health, but people just do not want to start those conversations. And so one of the things we want to do is to create more of those anti-stigma campaigns, right? Whether it's a small poster in a doctor's office, or whether it is creating some kind of workshop or platform where people can come together and talk about those things. We don't even have those kind of platforms for service providers, let alone kind of community members. A lot of migrant folks do not speak English well, and some of them are still struggling, taking classes, still learning, and they're wondering, well, would it be possible to have some of this information about sexual health in our own languages, right? When we go to, I don't know, different organizations that serve migrant communities, is it possible to have some of this information available in the languages spoken by communities. And the last recommendation that emerged from this project is that a lot of migrants wanted to access this sexual health information at settlement service agencies. Settlement service agencies are doing a really bad job when it comes to sexual health. And as a matter of fact, when I often go and try to interact with settlement agencies, try to involve them in some of our work, there's just this kind of narrative that, you know, sex and drugs, sexual health, addictions, it's just not our priority right now. Well, it is not our priority, but what we're seeing right now, post-pandemic, is that our numbers are increasing. Our HIV numbers are through the roof right now, right? We're going to be starting pulling the fire alarm very soon with the Manitoba HIV program, telling how bad the situation is. So the situation is actually becoming worse and worse. So it is always a priority. And I think this narrative is not really even ethical. Like, it's the health of marginalized communities. So that's really kind of the main findings that have emerged from this particular project with this population. This population, we also got a lot of interesting findings where communities told us that they face a lot of racism in healthcare settings. And sometimes it might not be like overt racism or overt kind of discrimination. Sometimes it's also something about the capacity of service providers, right? So one of the interesting things that we want to think about is how do we create those safe, non-judgmental, culturally responsive healthcare, social care settings. We have this interesting term that's called anti-racist primary healthcare. How do we as Manitobans think about creating healthcare which incorporates some of those elements of anti-racism, social justice? A few seconds ago, I showed you some of the findings with the sexual and gender minority populations, where I showed you that the community doesn't feel comfortable talking about their sexual identity, sexual practices. Now we have something different but similar with racialized communities, where we're seeing the issues of racism, stigma. So how do we create those healthcare settings that are conducive to cultural sensitivity, that are conducive to safe spaces? This is a big issue in Manitoba that we really need to address if we are thinking about marginalized communities. And so I've talked to you about one population, another population. Here's the last bunch of slides. This is a different last project I want to present you with. This one focuses specifically on First Nations, Inuit, Métis communities, urban indigenous communities. And this project we've decided to do both across Manitoba and Saskatchewan. And part of the reason why we decided to look at both provinces is because the Manitoba-Saskatchewan borders really don't work when it comes to indigenous communities, different First Nations reserves communities that actually span across two different provinces, right? If you go to Flin Flon, that's like totally at the intersection of Saskatchewan and Manitoba, for example. So this project was initiated by myself and guided by an elder and knowledge keepers across Manitoba and Saskatchewan. And one of the big things here with First Nations Inuit Métis communities, what we're seeing right now in those two provinces, it's a very unfortunate situation. Saskatchewan, the highest rates of HIV. Manitoba, second highest rates of HIV. So something is happening in those two provinces. Something is happening. When we started, it was already a bad situation last year. This year, new data is coming out from the Manitoba HIV program, which is telling us that the numbers are increasing even more. Unfortunately, Indigenous communities and women are the ones who are most overrepresented in our HIV numbers in Manitoba, for example, right now. But what we also heard, so this project was about the impacts of the pandemic on Indigenous people living with HIV. So those who were already infected with HIV, we wanted to know, how was your life? Like, were you able to go to the doctor, get your HIV meds? Were you able to how did you fare through this pandemic? But what was happening, very interesting, is Indigenous communities were very resilient, and a lot of organizations, a lot of agencies provided a very coordinated, resilient, strong response in the communities. So there's a lot of resistance. Like, it's not just people are marginalized, everything's bad, nobody's doing any kind of work. It's not like that. People are pushing, people are doing things. And so we came up with this project, Gigi Bapamin. It's a really interesting kind of story. Roger Roulette, Ojibwe language specialist, gifted us this name. Roger Roulette sadly passed away last week, but his legacy is still with us. And he was a language specialist, Ojibwe language specialist, and working with an elder, he came up with this term, Gigi Bapamin, which means we survived. And the story goes as following. When Ojibwe people would meet with other groups in the spring, saying Gigi Bapamin was an expression that they shared, acknowledging that they have survived the long winter. And in this project, the sentiment is applied to the survival of Indigenous people living with HIV through COVID pandemic. And the story upon which this term is based actually comes from the Ojibwe creation story, which tells how the Ninabuju creates the Turtle Island, North America, and then after the Great Flood, the loon otter and the muskrat play the key roles in retrieving plant and the piece of earth from the old world from which the new ones is created. And so the elements of the research logo that we have there, the Bapamin logo, really represents the animal world, the plant world, the rebirth of life, the directional medicine wheel, the four kind of sections of the medicine wheel. So that was really kind of the inspiration. I just wanted to share a little bit of that story with you because really that resonates a lot with communities. But on a pragmatic level, this project was a community-based participatory project. And when I say community-based research, what I mean is changing the whole worldview of how research is conducted. In community-based research, what we do differently from traditional research, we invite the community. So if I was to do research with you, I would invite you and ask you, help me conceptualize this research. Help me create the research questions. Come help me do the interviews with communities. Let's analyze this research together. Let's publish reports together. So that's a community-based research versus more traditional research where academics with more privileges would just conduct research and just give you the findings, and this is a truth. Believe in this, right? So in community-based research, it's a different model of research. It's a model that values the voices of the community, and so all research projects are conducted with that methodology in mind. But this one in particular had that element of community-based research, and here we try to interweave both Indigenous ways of knowing and Western ways of knowing to better understand how the pandemic affected this community. So this is kind of the project objectives, but the main idea is how did the COVID-19 pandemic affect people living with HIV? The team is very big. We have many different organizations and communities across Manitoba and Saskatchewan working together. We have community guiding circles. So this goes back to community-based research methodology. What we do is we create those circles of community members. So we have a circle of 10 individuals in Manitoba, Those are people who are Indigenous and living with HIV who are guiding our research. We have a circle in Saskatchewan, folks from the community, once again, who are guiding this research. So that's what I mean about community-based research. It's very much guided by community members as opposed to academics, right? We used a decolonizing community-based participatory approach, a two-eyed seeing. Two-eyed seeing is an approach where we say, you look at your research with one eye, which is a Western eye, and also with an eye that's indigenized, which prioritizes the voices, the knowledges, the histories, the cultures, the practices, and the protocols of the indigenous people. And so that's called two-eyed seeing approach, seeing something from one eye and the other eye. And so we did 40 to 40, we're still doing this project. This project is still actually ongoing. We're planning to conduct approximately 45 interviews with community members and 10 interviews with service providers. This is our beautiful recruitment poster that we're using to recruit communities for this research. So to be eligible, people had to self-identify as either First Nations, Inuit, be a person living with HIV, and live in Manitoba or Saskatchewan. So the interviews take approximately 1 hour, and we pay people $100 for that 1 hour. We also offer people an opportunity to smudge, to participate in ceremony before they do research. So it's really kind of indigenizing that research, decolonizing and indigenizing that research. I want to leave you with some interesting quotes in the next couple of minutes that just kind of emerging. What are some of the pressing issues in the community? So those are not my words. Those are the words of participants that are coming through the interviews. So people told us they were extremely isolated during COVID-19. I lost a job because of COVID-19. The factory that I was working got shut down. I had to go on EI. I ended up losing my job. I ran out of money. And this is kind of an example on the impact on communities. A lot of issues with access to HIV doctors during COVID-19. I haven't seen my doctor for all those years that COVID was happening. And there were quite a few times that I had to go without my medication. So there were days, I think, I went 4 or 5 days before I got my prescription refilled. That's a very dangerous situation to go off of your HIV meds and not have access during the COVID-19 pandemic. A lot of folks who maybe had some history of substance use spoke about how the pandemic was really triggering them. So here the interviewer is asking, you mentioned you've been sober for 10 years. In terms of somebody who had lived experience of using substances, how did the pandemic affect you? I think it brought back memories because I was isolated and everything. If I was using, I wouldn't have given a shit. I would have still been communicating with my street family or whatever, been out doing what I was doing. So it took me back. It took me to the dark place. I guess you could say that I was wishing and hoping and everything that I would go out and use again. I do believe I even contacted one of my nieces and who sells cocaine, and I asked her if she could get me some powder and some heroin. I went that far. It was quite scary. I was glad that she declined and she knew that my sobriety meant that much to me that she didn't want to get me started again. Even though she's using, at least she had enough moral and love for me not to give in to my evil thinking. So this is one example of many narratives like that. We got a lot of information like that where participants spoke about the issues in the community when it comes to substance use, how that was triggering. Some many more pressing issues have emerged through this research. Food security, the lack of drop-in services, safe places, So there's a lot of issues like that in this community. Isolation, fear, economic difficulties, loss of community, access to doctors, worry about navigating sobriety when it comes to substance use and drug use, worry about relapsing back, stigma, access to doctors, food security, and access to many harm reduction medications. This is an elder that I'm working with and part of this project, Elder Albert McLeod, who's been very instrumental. So we're still continuing with that particular study. The other projects are completed, but this one is still ongoing. So this is all that I wanted to present to you. So you've been bombarded today with a lot of research data and information, but that is good. That's part of my job, to go around and share this information and tell communities how bad the situation is when it comes to marginalized communities and healthcare access or healthcare outcomes. So it's been really a pleasure speaking to you about my work. I'm going to open the floor if folks have any questions or comments or anything that's on your mind, maybe that you would like to ask.
Are you optimistic about the future of this particular research?
Yes, very optimistic about research, not so optimistic about our kind of structures in which we find ourselves, not so optimistic about the politics in which Manitoba finds itself, not so easy to do this kind of research sometimes. Everything goes back to also funders who fund this research. Sometimes it's hard to get money from funders when you explore sensitive topics like that. But as you also can see from our successes with funders, we're also trying our best to get this kind of resources to conduct this research. What is really difficult for me is we're finding all these important things through research. But then when we're bringing these findings to policymakers or government, nobody's doing any work, right? And suddenly we're facing this resistance from political, social kind of structures. So that's really what's difficult. It's easy to do this research. It's easy to engage communities in this important health research. It's hard to make changes in Manitoba.
I was just wondering, where is the Village Lab located? Is it at the university or elsewhere?
Yes, it's housed in the Faculty of Social Work. Yeah, at the University of Manitoba. And we are doing a lot of work in terms of expansion now. So it's housed in the Faculty of Social Work at the University of Manitoba. Yeah. But we also do meetings at a variety of community organizations. Not all marginalized communities, particularly when we do interviews, want to come to university settings, right? A lot of people actually feel safer coming to some community-based organizations. Unfortunately, there's a particular history of exploitation when it comes to research of marginalized communities by academics. So there's a lot of consideration that also has to happen when we do research like that, and how do we do outreach to communities. Maybe when we conduct studies, it's not about inviting people to come to academia, but it's actually going out there, doing interviews, doing research in communities in those settings. So it's a very kind of mobile atmosphere in a sense too.
I'm just interested a little bit on the rate of HIV in Manitoba, Saskatchewan.
Yep.
Just wondered if that's related to overall population. Rather, like I think of Montreal, Toronto, Vancouver, just wonder why we're so high and what we're doing about it, I guess.
Yeah, so I'm just looking at the newest numbers. I'm not just playing on my phone, I'm actually looking at the HIV numbers. Our current statistic is 1 in 2 cases are female. 8 in 10 individuals actually heterosexual. 7 in 10 indigenous, and 8 in 10 are people who use injection drugs. So I think multiple things are layered here. The first one is increasing injection drug use, and that's what's driving the numbers. Another thing is access to services. So like I told you, this communities can't talk in healthcare settings about this. That communities feels like it's discriminatory. So people are not making to healthcare settings. People are less likely to be tested. And so if you're less likely to be tested, you can go get medications, you can get care. So the pool of infectious disease is kind of growing through those kind of dynamics. And then, of course, all the political and social context in which the province finds itself. We don't have enough funding for harm reduction programs. We don't have enough funding for HIV services. We don't do enough innovations when it comes to drug use, HIV. I'll give you an example with the HIV prevention drug. There's an HIV prevention drug called PrEP, pre-exposure prophylaxis, where people can take a pill to prevent HIV. So if somebody knows they're maybe engaging in some kind of risky behaviors, they can take this pill to prevent HIV. So people who are injecting drugs, people who are engaging in unprotected sex, people who are involved in sex work. So those communities are recommended to take this prevention drug. But Manitoba only started to fund this prevention drug this year. So this prevention drug only went on provincial formulary this year, right, and became free for communities before people had to pay for this prevention drug. So it's things like that. It's things how behind we are. Everybody else in Canada had this prevention drug. We didn't have it. The only province in Canada. So in many ways, we are behind in terms of our health policies, public health policies, and all that important action that needs to take place. And part of it is we don't have good leadership. We need somebody to step into that leadership position to advocate. And when things are being advocated, somebody at the government level also needs to be responsive. So we don't have that dialogue right now. And that's why the numbers are going up.
I wanted to do a follow-up question on the first question, which was about asking you about your, if you thought, what the success rate was and if you're, hopeful about things. So you said that, so I think we've heard many times at our province, there's a lot of things that can be that left to be desired in terms of where we are in terms of moving forward. But what province is actually doing it right? Like, is there another province or provinces out there where the government is doing the things that you said that we need to be doing, that we should be looking at as a model?
It's all kind of relative and comparative. One might say that if we look, for example, at innovations in HIV prevention, in drug use kind of support, and we'll look at things like supervised injection sites. Supervised injection sites are those medically supervised sites where people who use injection drugs can go and inject their substances, but under supervision of a nurse, of somebody who will guide them. And what it does, it prevents overdoses. It prevents people from dying, just basically as such, right? And so other provinces are doing a better job at, for example, supporting life-saving prevention mechanisms like supervised injection. This is just one example, right? We can look at many different examples, but that's one thing that other provinces are doing better. Here we don't have political support, we don't have financial support, and actually we have a lot of resistance in Manitoba to innovations like that. So in Ontario, we see an emergence, even sometimes of unsanctioned supervised injection sites. And what that means is community organizers open those sites. They might not, they kind of operate at semi-legal level, but it's also, they're not being shut down by enforcement services, by police. No, on the contrary, the different jurisdictions, different professionals are working together to improve the health and well-being of marginalized communities. Here, things are more disconnected, not working so well. So that's an example, like Ontario, British Columbia, they're doing quite a lot in terms of safe supplies of substances. They're doing quite a lot in terms of prevention drugs. Like I give an example with prevention pill that wasn't put on provincial formulary. Every other province has done that. And we've been behind for 5, 6, 7 years in terms of doing that. But even if things don't work well in Canada, we can look at other jurisdictions internationally. UK, Australia, that are doing a very different job. We're also doing a terrible job in Manitoba in terms of even collecting statistics in the first place. Like, we don't do good enough job, for example, collecting ethnicity data when it comes to HIV. So it's hard to calculate, like, okay, this number of Indigenous people are affected, this number of these communities are affected, this number of Black African Caribbean communities are affected. So to even guide us in the right direction, we're not even collecting data. So a lot of issues at the level of data collection, surveillance, prevention, and also care when it comes to services. So simply, we have a lot of work to do. Yeah. Yeah.
I'm just wondering what you or who, someone else is doing to bring this information to the general population of Manitoba.
To the general population in Manitoba, I mean, one of the things I'm connected to is this, it's called the Collective Impact Network, Manitoba HIV Collective Impact Network. And it's a platform for researchers, provincial strategists, policymakers, funders to come all together to work on those policies. So those kind of entities conduct sometimes webinars or workshops where those stakeholders are invited. So it's through those mechanisms that most likely communities being exposed to this knowledge. I do public talks as much as possible. I go to different organizations, community-based organizations. But often we get people who are enthusiastic about this work, right? It's hard to really convince everyone in terms of like, we need the support, we need to move in that direction. So I think that part also needs to be done strategically. And it also assumes that people have power to affect those policies, those healthcare policies, public health policies, when we know that a lot of power is in the hand of the government.
Although there's an election that within less than 12 months.
Yeah, yeah.
Any other last questions?
Do you speak to the Indigenous educational institutions? The students there tend to go back to their home communities, and they're very respected for what they bring from school.
Yeah, we definitely, one of the things that we're planning to do actually is the last project that I've presented is still ongoing. So once we collect the data, we properly analyze it, one of the things we want to do is doing outreach. So going out to Indigenous communities, First Nations reserves across Manitoba, doing that education. Our guiding circles, community guiding circles, have expressed interest to just go together, like rent a bus, go together, do this education. We work with students, trainees, undergraduate students who are Indigenous themselves, who are connected to our project. And through that social networking, word of mouth, that education piece is also happening. That networking is also happening. Yes, absolutely, that's a very important strategies of engaging community in those issues, in this research, so that the community can go back and do the knowledge transfer back to their own communities. That's when we find community-based projects are the most effective.
Well, thank you very much. That was amazing, very interesting. Thank you, Rusty. Really
My pleasure.
appreciate that. So you all have now all of this knowledge. So, and you can see how passionate Rusty is about it. And there's lots of great conversations. So I encourage you to share this information and share the work that Rusty's doing with friends and colleagues and whatnot. And you have the power now that you've got this information in terms of what you do with it. So thanks again for attending. Again, there's coffee, there's cookies. Next week's, sorry, not next week, the next one, which is November 24th, in 2 weeks. And that the presenter for that one is Dr. Nora Lou Roos, and she's a professor emerita from the Department of Community Health Sciences in the Rady Faculty of Health Sciences. And her topic will be better income leads to better health and well-being, which helps people get their benefits. So that will be really interesting. I know she's really focused on social determinants of health as well, and how income and socioeconomic status impacts one's health. So you won't want to miss that. If you haven't registered, please do. There's still time. So thank you again. Have a wonderful day, and we will see you in a few weeks.